morning, good evening, and good afternoon to our speakers, chairs, and the wonderful audiences of ACNS webinars. Today, we have two great educational lectures lined up for you. The first speaker of today is a giant in the field of spinal surgery, Professor Michael Fillings. Professor Fillings is a professor of neurosurgery and vice chair research in the Department of Surgery, full member of the Institute of Medical Science School of Graduate Studies, a scholar in the McLaughlin Center of Molecular Medicine, a scientist in the McEwan Center for Regenerative Medicine, a senior scientist at the Incremental Research Institute, co-director of the University of Toronto Spine Program, head of the Spinal Program at the Toronto Western University Hospital, and Gary and Tutsi Halbert Chair in Neural Repair and Regeneration. Previously, he was the director of the University of Toronto Neuroscience Program and medical director of the Incremental Neuroscience Institute at the University Health Network. His main clinical research are in the field of spinal surgery, and research is focused mainly in the molecular mechanisms underlying spinal cord injury. We are extremely thankful to Professor Fillings for accepting our invitation to be a speaker at our webinars. Today, he is going to talk about current status and future trends in the management of degenerative cervical myelopathy. The second speaker for today is Professor Xu Wei from China. Professor Xu Wei is Associate Professor, Department of Neurosurgery, the Beiping Hospital of Army Military Medical University, Chongqing, China. He is a cerebrovascular expert and a young neurosurgeon, and we are extremely thankful to him for accepting our invitation to be a speaker at our webinars. Today, he will speak about bypass-assisted clipping of complex MCA aneurysms. The chair for the first session of today is Professor Salman Sharif. Professor Sharif is the head of Department of Neurosurgery, Liaquat Medical School, Karachi, Pakistan. He is the secretary of the World Spinal Column Society and also the co-chair of the WFNS Spine Committee. He was the past vice president of the Pakistan Society of Neurosurgeons. He is a noted author and researcher who is on the editorial board of several journals. We are extremely thankful to him for accepting our invitation to chair today's webinar. The chair for the second session of today is Professor Fusao Ikawa. Professor Ikawa is the director, Department of Neurosurgery, Shimane Prefectural Central Hospital, Izumo, Japan. Professor Ikawa is a prominent member of the Japanese Neurosurgical Society and the WFNS. He has vast experience in cerebrovascular neurosurgery and is a noted author and researcher with several publications in various peer-reviewed journals. We're extremely honored and thankful to him for accepting our invitation to chair today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs to this online platform of ACNS webinars. Dr. Liu Boon Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over this platform to Professor Salman Sharif.
Thank you. It's really an honor to be in such a webinar where such giants of neurosurgery, spine surgery are taking part. Regarding the topic, we all know this is a controversial topic in many ways and was controversial for some time until our friend Michael Fillings came along and did a lot of research on it. And there's so much work he's put in there that because of that, now we have all those uncleared questions were answered in majority of the thing regarding postulation, hypothesis, sleep deprivation was causing it, or too much of sleep is causing the problem, dietary habits, protein, salt intake, and all those questions regarding pathophysiology, the role of surgery, how early, when, where, what about radiological outcome, the clinical outcomes, there are different scoring systems. And, you know, all this he's changed since he's started publishing really massively on this since 2017. And talking about approach, you're going to come in anteriorly or posteriorly, how you're going to go about it. And his work in spinal cord injury has been really outstanding. You know, he's a brilliant researcher, and the work he's done for this is amazing. And I'm looking forward to this talk, and just like everybody else, I think it's going to be a feast for us. Mike has already been introduced, so I'm not going to repeat all that again. It's our pleasure to have you, and you can share your slides now. Thank you.
Good morning, good afternoon, and good evening. I'm Michael Fillings from the University of Toronto, and it's a pleasure to take part in this a special webinar from the Asian Congress of Neurological Surgeons. So in the next few minutes, I'll be sharing with you some thoughts around the current status and future directions in the management of degenerative cervical myelopathy, which is the commonest cause of spinal cord impairment worldwide. There have been many advances that have occurred over the past 10 to 15 years, and there are also many unanswered questions that remain. I have no relevant commercial disclosures. I receive funding support from a number of sources, and I am the principal investigator on one of the clinical trials that I will be referring to. I'd like to thank the organizers of the ACNS, to recognize Professor Yoko Kato. I'd like to recognize my esteemed chair, Dr. Salman Sharif, and the other key organizers that are recognized on this slide. And it's also a pleasure to share the podium with an outstanding young investigator, Dr. Ming Wei from China. This is where I work in Toronto at the Criminal Neuroscience Center. And I wish you all greetings from our beautiful city. Of course, we're currently in lockdown, but in the future, please visit us. And I want to acknowledge my wonderful team as well in our center at the Toronto Western Hospital. What I'll be speaking to you about is somewhat reminiscent of this famous painting by Paul Gauguin. And this is entitled D'où venons-nous, que sommes-nous, où allons-nous? And the English translation is, where do we come from? What are we? Where are we going? And I think that this is very relevant to the consideration of degenerative cervical myelopathy. This is the outline of today's lecture. So I'll be reviewing the concept of degenerative cervical myelopathy as an overarching term that encompasses many different pathologies that we treat. And I'll be talking about the surgically relevant pathobiology and then reviewing the surgical options. I'll be talking about some of my own philosophies on anterior versus posterior surgery and presenting the results of a recent randomized controlled trial that we participated in on anterior versus posterior surgery. I'll then present evidence which indicates that surgery is efficacious and is cost-effective, and I'll be reviewing the recent AO Spine guidelines on the management of degenerative cervical myelopathy. I will then talk about knowledge gaps in future directions, and we have a challenge to optimize the management of mild DCM, and I would like to present to you microstructural MRI as a promising imaging biomarker and share with you some tools that I think you could use very easily in your own clinics. We also have a requirement and an opportunity to optimize neurological outcomes by translating some of the basic science discoveries to the clinic. And I'll present one effort to do this. This is the CSM Protect study in which we examined the sodium channel blocker, riluzole. There are three learning objectives for today's talk. One is to define the concept of degenerative cervical myelopathy. Secondly is to articulate the current AO Spine CSRS guidelines for the management of DCM. And thirdly, to list the key knowledge gaps in our understanding of DCM. A few years ago, we coined the overarching term degenerative cervical myelopathy. And more recently in this Nature Reviews article, we covered the some of the key concepts in the future directions. So DCM is an overarching term that we coined in 2015, and it's intended to encompass a variety of benign, non-neoplastic and non-traumatic pathologies and to try to bring the field together. The two most common pathologies are those of cervical spondylotic myelopathy, or CSM. And this also has a variety of manifestations. There can be spondylolisthesis, deformity, and other issues. Of course, OPLL, which is quite common in the South Asian and East Asian communities. And we actually see a lot of this in Toronto because of the large immigrant populations that we treat. And then there are other rarer conditions, including ossification of ligamentum flavum, and then of course other genetic conditions, including Klippel-Feil, Ehlers-Danlos syndrome, and so on. The pathology of DCM, in many regards, resembles that of traumatic spinal cord injury, with the critical exception that there is not a hemorrhage. And the majority of the cell death that occurs is as a result of progressive compression of the cord. And Here again, we see representative MR images, and on the bottom are images from an animal, a model of spinal cord injury, and one can see the profound loss of gray and white matter. So we think about the pathophysiology of DCM as involving three critical factors. So there are static factors, and this is the compression of the cord, and this also results in subsequent ischemia. Then there are dynamic factors because the spine moves and there can be deformity that can result. And so there's dynamic compression and there's axial tension. And so this is also the rationale for some of the reconstructive procedures that we consider in our patients. But clearly there's more going on than simply the mechanical factors. And these are the biomolecular factors related to neural degeneration. And critical to this include issues such as inflammation, ischemia, and excitotoxic cell death due to the release of glutamate. Now, the classification at a clinical level has been a subject of some discussion, and we owe a great debt to our Japanese colleagues who devised the Japanese Orthopedic Association scale a number of years ago. And in an effort to internationalize this, the modified JOA score has been created, and I would suggest that this now be considered the standard that could be applied internationally. This was first conceived of by Benzel, and then our group has subsequently gone on to define the psychometric properties of this scale and to validate this. One considers mild DCM as being patients with a score of 15 to 17, moderate 12 to 14, and severe is quite a wide group, 0 to 11. There likely is a less severe group and then a more severe group. And again, just to remind you, there are four critical domains. There's the motor dysfunction in the upper extremities, motor dysfunction in the lower extremities, the assessment of sensation, and the assessment of sphincter dysfunction. Now, we've just scratched the surface in the consideration of the genetics of DCM, and this is an opportunity for further research. We recognize that certain congenital conditions, including Klippel-Feil syndrome, trisomy 21, Ehlers-Danlos syndrome, have higher rates of DCM. There are some genealogical clustering studies, for example, the study by Patel out of Utah, which showed familial clustering among first-degree relatives. And we recognize that OPLL has a higher incidence in the Asian population, particularly South Asians and East Asians. And there are some potential genetic risk factors that have been recognized. For example, ApoE4, it has been recognized in the susceptibility of the spinal cord to ongoing compression, and a number of genes, including those related to TGF signaling, phosphatase signaling, and bone morphogenic proteins, have been related to ossification of the posterior longitudinal ligament. Now, when we think about the intrinsic molecular cascades that occur in the spinal cord, it's important to have a basic understanding of the mechanisms of cell death. And this is an oversimplistic cartoon, but from a clinical perspective, it's helpful to think about the two principal forms of cell death. One being necrotic cell death, and this is the principal form of cell death that occurs after traumatic injury. The principal form of cell death that occurs in DCM, however, is not necrotic, it's apoptotic. And this relates to the activation of genetic programs that then cause cell death. A few years ago, we adapted this model that was first described in Japan. This is the Twi mouse model of cervical myelopathy. And here in the upper right, we see a sagittal image, and these animals get spontaneous ossification of ligamentum flavum in the high cervical cord, and this causes severe compression of the cord, and these animals develop a spastic quadriparetic phenotype. And in this paper that we published in Brain now a decade ago, for the first time, we really examined the intrinsic molecular mechanisms using both human postmortem tissue as well as animal model data. And we clearly showed that apoptosis was a critical issue in cervical myelopathy. These are images from human tissue as well as some of the rodent model tissue, and showing activation of the fast death receptor. And this is linked to apoptotic cell death. And this can be measured through an assay called Tunnel, which measures cleaved DNA, as well as caspase 3, which is an enzyme, which is a marker of apoptotic cell death. And so we came up with this schema of some of the molecular pathways and cellular mechanisms. So chronic compression of the spinal cord results in ischemia. There's inflammation that occurs, which activates microglia T cells. And in addition, the ischemia directly activates death receptors. And these two cascades coalesce to cause apoptotic cell death. Now, of course, the pathophysiology is much more complex than I'm depicting here. And this does represent areas of future research opportunity. So let's switch gears and think about the clinical issues that we undertake. And this is a focus issue that I chaired a few years ago, which nicely summarizes a number of the clinical considerations in the management of cervical myelopathy. And I thought I would share with you a few cases. I continue to have a very active practice in complex spine surgery, and I treat 5 to 6 patients a week with cervical myelopathy typically. So this is a patient who has a kyphotic deformity. It's an at-disc level pathology, and it's partially reducible. And I'm a big fan of the multi-level anterior cervical approach. And most of these cases can be done standalone, as shown here, with a nice reduction of the kyphosis, a good decompression. This patient had an excellent result. And then on occasion, one needs to combine this with a corpectomy. And this is a so-called hybrid procedure where we combine a corpectomy with intervening points of fixation. And again, one can avoid a posterior approach in these cases. And then there are posterior options. So in multi-level cervical spondylosis, where there is significant degenerative issues in the spine, a posterior laminectomy infusion, I think, is an excellent option. And then, of course, laminoplasty, which was developed originally in Japan, and is now gradually transitioning around the world, is also a good option for multi-level stenosis with preserved lordosis, although one needs to be cautious in the setting of significant kyphosis or instability. And then on occasion, combined anterior and posterior approaches are required. And in my hands, I'll use this in patients who have a fixed kyphosis, where a combined anterior posterior approach is optimal, generally where a multi-level corpectomy is required, and then we'll reconstruct the posterior tension band. You can see the very significant degree of kyphosis here. We've corrected this with an anterior multi-level corpectomy approach. And then here we have gone up to C2 with pedicle screw fixation, multi-level laminar lateral mass fixation, and then distal pedicle screw fixation, an excellent decompression, and a significant restoration of sagittal alignment. Now, there has been some controversy in terms of what are the best surgical options. And in some patients, there clearly is not equipoise. If there's significant kyphosis, generally an anterior approach is preferred. Multi-level pathologies with posterior compression, dorsal approaches are optimal. But then there are patients in which there's equipoise. And this is a recent randomized controlled trial. Senior author is Zohair Gogawala from the Leahy Clinic, and our unit in Toronto was one of the participating centers. So in this clinical trial, we set up a spinal expert review panel. We would review cases such as this case, where there are options. One could consider a case like this potentially for a multi-level anterior approach, also for a posterior type of approach. And the patients underwent thorough imaging and then a spinal expert review. And if it was felt that there was equipoise between anterior and posterior surgery, the patients were then randomized to have anterior or posterior surgery. And these are the results. So patients had either anterior surgery combined with a fusion, a dorsal laminectomy infusion, or dorsal laminoplasty. And these are the results at 1 year. And the principal outcome was the SF-36 score. So this is looking at the change scores, and this is looking at the trajectory of the outcomes. Here on the on this side, we see the posterior surgeries with dorsal fusion or dorsal laminoplasty, the majority of the patients showing improvement in function. And then these are the cases treated with an anterior approach. And the bottom line here, and this is also showing the trajectory of changes, is that really all three options provide excellent outcomes at a year. And we're now trying to dissect out the subsets of patients that might be more optimally treated with anterior posterior types of approaches. Now let's reflect on the significant costs of a DCM to society and issues related to cost effectiveness, because we're all working in a world where the economic issues related to healthcare are becoming an increasingly important issue. It's clear that DCM has a significant cost to society as well as to the individual when one considers the economic productivity losses, the disability costs, and so on, and the impact on the patient in terms of quality of life, independence, and so on is really profound. Now, we lack granular costing data in patients with degenerative cervical myelopathy, but one can get an estimate of the impact of DCM by looking at traumatic cervical spinal cord injury and considering patients with an incomplete deficit in patients who are in the middle years of life. And if we look here in the purple line here, we see that the costs from a North American perspective are really quite substantial and can literally run into hundreds of thousands, if not over $1 million. So this is a very expensive condition. We've also seen a paradigm shift in terms of the treatment approaches of degenerative cervical myelopathy, but also the consideration of the value of surgery. And in addition, to be candid, although non-operative management has been touted as an equivalent treatment for cervical myelopathy, there are really insufficient data to suggest that non-operative treatment can actually result in improvements in DCM. So these are box plots from two of the prospective clinical studies that I led. This is the JBGS paper from the North American Multicenter series. We see significant improvements in the MGOA scores, significant reductions in the neck disability index. This is an index of impairment, and substantial improvements in the SF-36 physical and mental component scores. And all of these were well above the minimal clinically important differences. A few years later, in this article published in Spine, we reported on a similar study that was undertaken at the global level, and this included patients from North and South America, Europe, and the Asia Pacific regions. And again, we see virtually identical results, significant improvements in all of the domains that we examined. And so clearly there's been a paradigm shift, and we now recognize that surgery has a critical role in the management of DCM, that this is not a situation where we are pessimistic on the outcomes of surgery. And in fact, we can do much better than halting neurological deterioration 80% of patients show improvement in neurological function with surgery. Now, what was a knowledge gap when we set out the study that I'll talk about in a moment was, well, that's fine, but what is the value of surgery? Is it a cost-effective intervention? And so to examine this, we used the data from the AO spine studies, and then we took advantage of the accurate microcosting data in the Canadian setting, which are actually very applicable at an international level. We took the perspective of the pair. We used accurate microcosting data. We then calculated the costs at a very granular level. And then we also looked at the improvements in function. And to do this, we calculated what are called health utilities. And one can then transfer the data from the SF-36 and calculate what's referred to as an SF6D. And then one can translate this into quality of life improvements. And again, we see very substantial improvements in quality of life with surgical treatment for DCM. From this, you can calculate what's called an incremental cost utility ratio, or ICER. One looks at the costs of surgery, the costs of non-operative management, and one looks at the utilities. These are the improvements in function in surgery versus non-operative treatment. And then the WHO has defined a very cost of intervention as the costs related to gaining one quality adjusted life year. In the Canadian perspective, based on the gross domestic product per capita, this is $54,000. And this is very similar in virtually all developed countries in the world. To analyze this, we collaborated with a group of health economists at the University of Chicago, and this was the graduate thesis of one of our students, Chris Whithew. And they used what's called a Markov transition model. So here we model all the different outcomes that can occur with either surgery and non-operative management, improvements, complications, even deaths, and so on. And then one can then run this through Monte Carlo probabilistic sensitivity analysis to model all the different outcomes that might occur. And when we model this, 98% of the simulations resulted in an outcome showing that surgery for DCM was very cost effective. And we see that the costs were under $12,000 for an ICER, well below the $54,000 per quality adjusted life year that it's cost effective. So this paper won the Outstanding Paper Award at the North American Spine Society. Chris Whithew, who's now on faculty at the University of Toronto, obtained his graduate thesis, and these are the collaborators on this work. So given this background, we felt that it was time to issue guidelines, which prior to this were lacking. And these were the guidelines that were published in the Global Spine Journal now in 2017. To undertake this is a two-step process. We undertook high quality systematic reviews, and we collaborated with a biostatistical group at Spectrum Research to do this. And then we composed a multidisciplinary international guidelines development group. So this is one of the forest plots from this complex analysis. And this shows the effectiveness of surgical intervention. So cast your eyes to the red box. The middle lines here are the point of where there is no improvement. The left side favors non-operative management and the right side favors surgery. And then these diamonds represent the mean improvement and 95% confidence intervals. And you'll see that these are highly significant improvements with surgery, and this includes near-term and then long-term follow-up data beyond 3 years. Armed with these systematic reviews, we then put together an international multidisciplinary guidelines development group. This included professionals from all around the world. We included neurosurgeons, orthopedic surgeons. We also included physicians from non-surgical disciplines, including primary care, and we also included patients and patient advocates. This is the grade process to derive guidelines, and you take the best quality evidence, so it needs to have high quality systematic reviews. You need to look at the clinical acceptability, and so you need to have experienced clinicians from a variety of backgrounds weighing the evidence. You need to consider the values of patients. You then need to look at the costs of the interventions and the benefits versus the harms. And so from this, we then derive the following recommendations. And for moderate and severe myelopathy, there was a very clear and strong recommendation for surgical intervention. In patients with mild myelopathy, there is greater equipoise. And so here, depending on the preferences of the patient and the judgment of the physician, one could either recommend a surgical intervention or a trial of non-operative intervention with careful follow-up. But if the patient fails to improve with non-operative intervention, we do suggest offering operative intervention. Now, an important concept that's emerging is that of personalized medicine. And so the idea of how can we predict how patients will do? And this was the first effort to do this. This was Lindsay Tetro's PhD thesis from our group. And Lindsay found that age, the duration of symptoms, psychiatric comorbidities, smoking, and the baseline level of neurological function, as assessed by MGOA and impaired gait, were critical determinants of outcome. There are significant knowledge gaps which will define future directions. We clearly need to optimize the management of mild DCM. So we need a better understanding of the natural history. We need to have improved outcome measures to more sensitively determine changes in patients with mild DCM. I would present to you microstructural MRI as an imaging biomarker, and I think that this is something that any clinic in the world could apply. We also need to consider the value of genetics in transcriptomic biomarker assessments. And clearly we need to optimize neurological outcomes. We all recognize as clinicians treating these patients that surgery is not perfect. Even in the best of hands, neurological complications can occur, such as delayed C5 palsy. Not all patients show great recovery, and most patients do harbor some degree of neurological impairment. And hence, there's a value to look at biomolecular strategies to enhance neural repair and plasticity. And I'll present to you a first effort to do this. This is the CSM PROTECT study. There are now clinically feasible microstructural MRI techniques available to quantify cervical spinal cord injury tissue damage. And this is a paper by one of our former students, Alan Martin, who's now in faculty at UC Davis, published 4 years ago in the American Journal of Neuroradiology. And I'll just show this to you in diagrammatic format. And so we have a variety of assays we can use. One can use T2 weighted to T2 star weighted imaging to look at atrophy and compression. One can look at the magnetization transfer ratio to look at myelination and demyelination. One can assess axonal injury using diffusion tensor imaging and calculating fractional anisotropy. And then one can look at a metric called T2 star weighted white matter to gray matter ratio to assess demyelination and gliosis and other issues. And this is the outcome measure I particularly want you to pay attention to, because this is very easy to do and I think is predictive of patients with mild myelopathy who will not do well with non-operative management. This is also a shout out to our medical physics collaborator at the Université de Montréal, Julien Cohen-Haddad, and he has an open source spinal cord toolbox. And these are tools that you and your neuroradiology team can use to assess the images. So this is the paper that was the foundation for Alan Martin's PhD thesis. This is the T2 star weighted white matter to gray matter signal intensity ratio. These are some images, and this reflects demyelination, gliosis, and other issues. And this showed a strong predictive value to determine which patients with mild myelopathy would not do well with observation and non-operative management. And we are now using this routinely in our own clinic in patients. And then the final set of data I will present are from the CSM Protect trial. And this was looking at the sodium glutamate blocker riluzole to potentially enhance functional outcomes in patients undergoing surgery for DCM. Now, riluzole is a sodium glutamate antagonist. It's an FDA-approved medication, which has been shown in randomized trials to attenuate nerve cell degeneration in amyotrophic lateral sclerosis. And this is really a repurposing of an already approved drug. And this is the publication that came out in the Lancet Neurology a few months ago on this trial. So we recognize that although surgery is effective, generally, there are patients who can have perioperative neurological complications, in particular delayed C5 palsy. And this can occur in approximately 5% of patients overall. This shows the recovery trajectories of patients using the MGOA scale with surgery. So most patients do show improvements, as shown in the blue. Then there are patients who remain neurologically stable and do not improve. And these patients harbor usually significant neurological impairment. And then there's a small proportion of patients that unfortunately show continued deterioration. So there clearly is a need for interventions that go beyond surgery. And we had quite extensive animal model data, including this article in Science Translational Medicine showing improvement in neurological function with riluzole. So based on this, we designed the CSM Protect randomized controlled trial, and the rationale for this was published a few years ago. This is a multi-center placebo-controlled, double-blind randomized trial. It was registered in clinicaltrials.gov. It was undertaken at 16 sites across North America. We enrolled 300 patients with moderate to severe DCM. The patients all underwent surgery. The patients were randomized to receive riluzole or a placebo in a double-blind fashion 2 weeks prior to surgery, and this was continued for 4 weeks after surgery. And then the primary outcome was looking at the changes in the MGOA, and we had a variety of secondary outcomes, including the assessment of pain, which has shown interesting outcomes in this trial. So ultimately, 290 patients underwent surgery and were analyzed. This is a distribution between riluzole and placebo, mean age of 58. Just under half of the patients were women, and we had excellent follow-up. You're not going to be able to read all of the points here in this table, but the point here is to show that we assessed a broad variety of baseline characteristics, and for the most part, the patients were quite well matched between the two groups. This is the high-level overview of the complications. The drug was well tolerated without significant issues in the patients, and overall, the complication profiles were similar in the placebo and riluzole groups. So the overall primary outcome measure did not show a benefit with riluzole. And this is likely related to the dominant effect of surgery, as well as the relative insensitivity of the MGOA to small changes in function. So here we see the MGOA scores at baseline and then very significant improvements in function with surgery, but no clear effect with riluzole. But interestingly, on the pre-planned secondary outcomes, we did see a signal with riluzole. We saw significant changes in both neck and arm pain as assessed on the visual assessment score for pain. And this was translated into an improved function on the subdomain on the SF-36. And there were also subtle changes in the Asia motor scores, likely reflecting improved intrinsic motor function. So in conclusion, related to the CSM Protect study, we saw that after a 6-week perioperative course of riluzole as an adjunct to surgical decompression, there was no significant effect on the primary outcome, the MGOA, but we did see significant benefits on 3 predetermined secondary outcomes: neck pain, the motor score, and the physical function domain. And so I think the effect of riluzole in reducing pain is of clinical interest, and potentially with a longer duration of treatment, focusing on patients who present with pain primarily, more sensitive outcome measures be of value. And I would encourage all of you in the audience to consider the use of riluzole in your practices and to assess the outcomes. So the take-home messages from this lecture are the following. DCM is the commonest cause of spinal cord impairment in the world. Surgical treatment of DCM is safe, improves neurological function, quality of life, and is cost-effective. There are many future directions to consider. We need an increased awareness of DCM, and this is a shout out to the AO Spine Recode project, which is undertaking this effort. We need to optimize the management for patients with mild DCM. We need a variety of biomarkers, including imaging, serological, and genetic approaches. And we need to consider neuroprotective and neuroregenerative strategies for our patients to further optimize spinal cord function. And on that note, I'd like to close and be very happy to undertake questions. Thank you very much.
Thank you, Michael. I think brilliant lecture as always. Enjoyed that thoroughly. I think every time I'm listening to you, there is something new I learn. I'm sure all our audience would have learned something as well. We are open to questions. If anybody has a question, I see that Atul is dying to ask a question. Atul, you're most welcome to ask the first question.
Yeah, Mike and Salman, it was nice to see you both on this show. Mike, your presentation is like a bibliography on the subject. And it will be not a wrong statement to make that the entire literature has been made by you and by your colleagues on the subject. So I want to ask you, I'm not sure if you have read my recent work, Mike. I am not sure. But you know, when you talk of pathophysiology of cervical spondylotic myelopathy, you indicate about static factors, dynamic factors, and things like this. So if you happen to read my articles, which are many in the last few years, I'm sure you must have read some. I have laid much more stress on dynamic issues, like instability as a major factor in the pathogenesis of the entire scenario, and instability led by the muscle weakness, inadequate muscle function, disuse of muscle, abuse of muscle, injury to the muscle. So these factors have an overwhelming effect on the pathophysiology of degenerative spine. And instability is the primary issue. So that is what my articles mention. The other thing that I have realized over the period is that in multi-segmental instability, atlantoaxial instability is a common association which has been neglected in the literature. Like when we talk of degenerative spine, we talk of C5, C6, C4, 5, but never about C1, C2, which is the most mobile segment of the body. So I am wondering what your thoughts are. I am wondering if you have read some of my work, and I am wondering if you think something positive of my work and what you actually think. I would like to know from you.
Thank you very much, Atul. So firstly, thank you for your very kind compliments on the impact of our work. That's greatly appreciated. And you have also made some very important contributions to the field. And I read your work very actively and have been a big fan of the techniques that you have developed for C1, C2 fixation, and also the reduction of the atlantoaxial segments by focusing on the C1, C2 facets. So thank you for that. So you've raised a couple of very interesting points. So one is the importance of the dynamic factors. And then secondly, the issues related to the muscle atrophy. And these are very important issues. So, you've developed some interesting techniques with facet distraction and stabilization, which I think is quite an interesting a technique. I haven't been using that myself in my practice, but I'm quite aware of this, and it's interesting. But I am in significant agreement with you around the importance of the dynamic factors. We have effectively stopped doing laminectomy alone for treatment of DCM. Of course, perhaps if one can look at maybe skip laminectomies to try to preserve the tissues. I'm not talking about that, but I'm talking about the wide, extensive laminectomies. And we have a recent paper as a sub-analysis from our work showing that the outcomes with laminectomy were inferior to either laminectomy infusion or laminoplasty. And one of my colleagues at McGill, Mike Weber, and his group have been looking, in fact, at some of the effects on the muscles, looking at MRIs on the muscles preoperatively in DCM, and there is significant muscle atrophy that occurs. And I think this is an important factor, both in the neck pain, but also in the issues that can occur post-surgery. And I think this is, one of the reasons why the outcomes with laminoplasty and laminectomy infusion are superior to those of laminectomy alone. Because if it was only a static factor, then laminectomy alone should be just as good as, say, laminoplasty, particularly in OPLL, where the spine is relatively stiff, but it's clearly not. Our Japanese colleagues have clearly shown that. So yes, I think that the points that you've raised are clear. And then with regard to your point on the atlantoaxial instability, look, you are the world guru on C1, C2 instability, and what can I say? You are also seeing perhaps a bit of a different patient population in India than we see. We do have a very international patient population in Toronto with a large Indian component as well, but we see a different mix of patients. So in my own practice, I do see patients who have atlantoaxial issues, and we pay a lot of attention to this. It's not as common, perhaps, as what you are seeing, but it is important to recognize this for sure. And I think one of the important points that I would say to the young surgeons and the students in the audience, you need to, when you're evaluating the patients, it's very helpful to get flexion extension x-rays to look for dynamic components. A CT scan is very helpful, as well as the MRI, to really have a complete view of this, and then to be aware that some patients will have craniocervical issues in addition to the subaxial issues. So thank you, Professor Goel, for your comments.
Thank you for that extensive reply.
And I'm for an opportunity to talk, and I'm looking for an opportunity to have this corona finish so that we can come and talk. And I have several issues to discuss with you. And of course, Salman is there. So best wishes to you. Take care, all of you. Thank you.
Thank you. Thank you very much.
Thank you, Atul. Thank you, Michael. Michael, just a question regarding, from the perspective of young neurosurgeons who are listening, where do you see the future of this disease? Where are we going? Is there anything particular or interesting or fascinating that you're working on, something new where we are going?
Oh, yes. I think it's very exciting. So, and there are opportunities at a basic science level. There are opportunities at a translational level and also at a surgical level. So at a basic science level, we now have wonderful animal models, and we really have the opportunity to dissect out the mechanisms and to figure out the causes of neural degeneration and to look at targets for treatment. And I think the issues like delayed C5 palsy, I think this is a solvable issue. I think it's largely related to ischemia reperfusion injury. From a clinical perspective, we need to solve the issue of mild DCM. I don't think it's acceptable to say to a patient, oh, you know what, I don't really know what to do. Let's just see what happens, right? I think we're entering into an era of personalized medicine. I think we should be able to have genetic, serological, imaging biomarkers to be able to figure out what to do. And then in terms of the surgical techniques and the outcomes, I think we're constantly looking at nuances to enhance the surgical techniques. And potentially we might be able to apply more minimally invasive approaches, particularly to some of the posterior strategies, and looking at ways to try to respect the anatomical constraints, to try to preserve motion, but also to preserve stability. And so I think there are many, many, many opportunities for translational research.
Brilliant. The other thing, people are worrying about, obviously, the MRI findings and able to predict beforehand which patients are going to improve and which patients are not going to improve. So if we tell patients beforehand that this is your probability of improvement, looking at your functional and radiological imaging. So what would you say would be one particular thing in radiology that's going to predict the outcome so that we can tell the patient beforehand?
Yeah, from the imaging perspective, if you see a reduced T1 signal in association with the increased T2 signal, that indicates myelomalacia, and so that has it's a negative predictor. Increased T2 alone is not a negative predictor, but if you see patients that have multiple levels of T2 signal change as opposed to one, that's a negative predictor as well. So the length of the T2 signal change, if it extends over more than one segment, in particular, if you see patchy areas. So these are some of the factors that if you see those, you may just want to counsel the patient, the family, that look, just to be aware that this may not be a situation where, you're going to get as good a recovery as you're hoping for.
Okay, brilliant. Do you have any more questions? Anybody? Just raise your hands if you want to ask a last question.
Ajitar is here with his question.
Yeah, it's a very, thank you for very comprehensive talk on this cervical degenerative spondylomyopathy. I just want to ask regarding certain new concept, because there is a lot of things coming up by assessing the spinal balance, because there is a plumb line even for the cervical spine. Do you think that is important in future for assessment of the progression as well as the treatment outcome? Next question is there any relation between this balance, cervical spine balance, with the development of lumbar spine disease, that is a degenerative lumbar spine disease?
So the questions basically, so thank you for those questions. The questions essentially relate to the importance of sagittal balance, and it's recognized that the presence of deformity is an important issue, and it's a very important issue in terms of determining the appropriate surgical outcomes. And I pay a lot of attention to this. So I personally look at the overall cervical lordosis. I look at the cervical SVA. I look at the T1 slope, and then I also look at the modified K line. And so those are some of the critical points that I look at. And there is an association between significant deformity and the outcomes of surgery. Although interestingly, patients with mild residual sagittal imbalance can still enjoy good outcomes. So it's not a perfect correlation, but I agree with you that it's an important a consideration to look at. And then in addition, in some patients, the changes in the cervical spine can occur secondarily to changes lower down. And so you need to look at the patient overall at a global level and sometimes 3-foot standing films, for example, in an ankylosing spondylitis case classically, are very helpful to assess. So thank you for your question.
Thank you so
Thank
much.
you. That's brilliant. I think we're running short of time.
Yes.
We're going to, yes. So I apologize that we ran over, but it was so much fun listening to all the answers and brilliant talk as always. Again, Mike, and a great discussion, Atul and all our friends. So we'll move forward. I'll let you take over, please.
Thank you. Thank you so much, Professor Salman Sharif, for chairing, and Professor Michael Fellings. It was a very wonderful lecture, and we had a lot of insights into the developing treatment and newer paradigms in the management of cervical spondylotic myelopathy. We wish to continue our questions further if you'll be staying back for the second lecture as well. But for the time being, I'll move on to the second chair, Professor Fusao Ikawa, who is here, who will be taking over, and invite Professor Zhu Mingwei for his lecture. Professor Ikawa.
Okay.
Yes, I got.
Yeah, yes. Okay. I'm Saoikawa from Shimane in Japan. And it's a great pleasure to be here and to see the colleague in ACNS, and in this interesting ACNS webinar. We cannot meet together recently in ACNS by COVID-19 pandemic. However, this is a good opportunity to take webinar in ACNS like this. This is necessary for the people in the world. And today, I'd like to introduce the Professor Mingwei Xu. He is the expert surgeon of aneurysms, associate professor, Department of Neurosurgery, the Damping Hospital of Army Military Medical University, Chongqing, China, the third biggest city in China. And his today's topic is bypass assisted clipping of complex MCA aneurysm.
And distinguished professors, good evening. It's my great honor to participate in this webinar. My name is Xu Mingwei. I come from Neurosurgery Department of the Daping Hospital of Army Military Medical University. Today, my topic is low flow bypass assisted with reconstructive clipping of complex MCA aneurysms. In the beginning, I want to introduce right clipping competition in China to you. It was launched nationwide by Chinese Neurosurgical Society and SQ Lab Company in 2014. This is a top academic exchange platform to promote the improvement of clipping technology. Also, so far this year, the RCRC has been successfully held for 7 seasons. And this year also held a special event for Asia Pacific, attracting the participation of outstanding neurosurgeons from Asia and Pacific countries. And so far, about 4,000 neurosurgeons have participated and concerned in this competition over the past 7 years. And each contestant has to go through online auditions, regional competitions, and finals, and to constantly improve their cases and can get professional guidance from many top neurosurgeons in China and make good progress. And my mentor, Professor Xu Mingwei and Professor Xu Bin, both won the champion on the first season of RCRC, and now they are all the most outstanding neurosurgeons in China. Unfortunately, I won the champion of the 7th season of RCRC this year and was highly praised by Professor Xu Bin and Yuha. So Professor Xu Bin gave me the opportunity to share my case here, and I'm a young neurosurgeon with limited experience. So I'm looking forward to all your correction. So I will convert to my topic. We know that complex MCA aneurysms usually cannot be treated with direct clipping due to their large or giant fusiform, dissecting, broad-necked, or serpentine morphology. So sometimes we may use reconstructive clipping. But when we mean the cases that the branch is arising from the aneurysm dome or neck, or involved disease at the neck or previous intravascular treatment or thrombotic aneurysms, we might use the technique of bypass assisted with reconstructive clipping. So complex MCA aneurysms require the surgeons to tailor their treatment strategy in each case. In our department, in treatment strategy for complex MCA aneurysms that cannot be clipped directly, we generally adopt the Hwasan Hospital's experience of three-type classification of complex MCA aneurysms, and the type A aneurysms originate from the M1 segment, type B from the M2 or MCA bifurcation, and type C from the M3 distal segments. Also, the very new approach of bypass, the medium flow bypass, can provide a flow capacity of 25 to 70 milliliters every minute. So it's suitable for treatment of most of M2 and MCA bifurcation or selective M1 aneurysm with or without stage IC occlusion. But however, the low flow STI MCA bypass is mainly used as a protective or vascular reconstruction of improved branches. So this is my case. This patient was 54 years old female, suffered from sudden severe headache and vomiting for 1 day. And she was lethargic when admitted with the Glasgow Coma score 13, normal name speech function. And CT shows subarachnoid hemorrhage, hand-hands grade fluid fissure grade 2. And CTA could see multiple aneurysms in the left MCA, and the giant MCA bifurcation aneurysm with a diameter of 21.5 millimeters. And this was a fusiform broad-neck aneurysm. So the diagnosis included subarachnoid hemorrhage and left MCA bifurcation aneurysm. And this is the responsible aneurysm. And inferior trunk aneurysm, also the aneurysmal enlargement of the superior trunk. MRI indicated annular enhancement of the aneurysm wall, suggesting inflammation or stenosis of the aneurysm wall. Also, we can see no mixed signals inside the aneurysm, suggesting a low possibility of thrombotic aneurysm. And DSA, we can see the blood feeding of freed MCA branches in the arterial phase, suggesting the importance of the intake preservation of all the freed MCA branches. In treatment method, endovascular therapy has so many difficulties. We can see that M1, the angle between M1 and inferior trunk, or M1 and superior trunk were acute. So it is difficult to super selective of the microcatheter. Also, the freed branch are difficult to be retained completely in endovascular therapy. And the long-term recurrence rate is higher than open surgery. So open surgery can guarantee the patency of all the MCA branches through clipping or bypass, which has my SLU advantage. So my surgical plan is reconstructive clipping of MCA bifurcation aneurysm and then the inferior trunk aneurysm. But we can see that this superior trunk arising from the dome of this superior trunk aneurysm. So it may be unclippable. So we can perform a STA to M3 bypass and tripping this superior trunk aneurysm. And this is the most, the simplest and most effective way to treat the free aneurysm at the same time. But before surgery, we should consider another problem. If the wall of the MCA bifurcation aneurysm was severely sclerotic, it cannot be treated with clipping, or it may cause stenosis of MCA bifurcation after clipping. So we should prepare another alternative plan to avoid clipping failure. So we can see this is a rupture aneurysm. So we have to completely tripping this aneurysm and reconstruct all the MCA distal branches. So if in this situation we are we will select radial artery and double STA to reconstruct or free the MCA branches or radial artery interpositional bypass. But these alternative plans are risky, and we should choose the most effective and simple method first. So pre-operative assessment, I think the most important is how to prevent intraoperative aneurysm rupture. We can see if this aneurysm rupture early in the operation, we don't have enough time to reconstructive clipping this aneurysm in a clean surgical view. So current research shows that the intraoperative rupture aneurysm is related to hemodynamic characteristics of the aneurysm. So preoperatively, we predict the rupture point through computational dynamic fluid dynamic technology. We can see this point, the washer stress and the velocity and the relative residence time was markedly different from the surrounding areas. So this may be the rupture point, and indicating that when we dissect it to this point, we should be very careful. Also, through this software, we can fully understand the vascular architecture also in the surgical position. Whether this aneurysm can be cleared successfully, I think that the selection of the aneurysm clip is related to the direction of the clipping. We can see that this is the frontal side and dorsal side of the aneurysm, and this in the surgical position. So this is the clipping line, this is frontal lobe, and this is temporal lobe. And the direction of clipping of this aneurysm may be this. So preoperatively, we prepared a lot of fenestrate clips to clip this aneurysm. Preoperatively, we also prepared multimodal neural functioning monitoring, including ultrasound, Doppler, and ICG-ography, and float 800 and MEP-SCP monitoring. Also, the blood flow assessment of the donor vessel of STA and radial artery. And this is the surgical position and incision. And we perform enlarged tear or craniotomy, and the head was rotated 30 degrees to the right. And this is the surgical video, the exposure of CVM fissure. We cut the CVM fissure and carefully remove the blood clot carefully and cut the CVM fissure distally. And gentle retraction and sharp dissection was preferable. And here we can see a small branch of MCA, and also can see a small portion of the aneurysm indicated that we should dissect it distally. And in the distal CVM fissure, there are many veins, so we have to protect them as much as possible. You can see this is M1, inferior trunk and superior trunk, and this is the distal inferior trunk. When we dissect it to the distal superior trunk, we can see this is the rupture point consistent with the preoperative analysis. And we can see the MCA bifurcation aneurysm with stenosis of the aneurysm wall and the branch vessels, and the superior trunk rising from the dome of the superior aneurysm. Also, we can see severe stenosis and stenosis of the inferior trunk. And this is lateral wall aneurysm. We performed ICG angiography and blood flow measurement by ultrasound so as to make comparison before and after clipping. Also, the blood flow in the aneurysm sec was 23.5. We then performed temporary clipping and then dissected the aneurysm thoroughly. Fortunately, on the dorsal side of the aneurysm, no perforated arteries adhere to the aneurysm. So we started to reconstruct the MCA bifurcation. The first clip was a curved fenestrine clip with a window of 5 millimeter and a blade of 7.5 millimeter. And the angle between the window and the blade was 45, and providing a very good intervention angle. So the second clip of the same size was inserted between the two superior trunks and then moved forward in tandem. And a third right angle window clip was used to accrue the remaining aneurysm neck. And the total occlusion time was about 6 minutes, and no blood flow change during the reconstructive clipping. But there are still blood flow in the aneurysm body, indicating not enough closure force of fenestrine clips. So here we use the spatial clamp T-back, which can provide greater closure force. So here are so many clips here, so we should avoid squeezing or moving between clips and resulting in stenosis of MCA bifurcation. And the fifth clip is still a short T-back. And here we could see the severe stenosis of the superior trunk. So we should ensure a large enough outer flow tract and prevent the stenosis of MCA bifurcation with multimodal neurological monitoring. But here, still blood flow in the aneurysm sac. So we can see that the only weak spot in the whole clipping line was here. So we place another fenestrine clips here. And then now no feeding of the aneurysm sac and good feeding of all three MCA branches. And we then dissected the inferior trunk aneurysm. We can see scanostic of the inferior trunk. So the first clip slip outward. So we need to use the second clip to accrue this aneurysm. But here now, this area has so many clips, so we have to recheck the blood flow here. And now MEP and SEP change during clipping. And then we puncture the aneurysm body and scissor the aneurysm wall to verify complete clipping. And here we can see the superior trunk arising from the superior trunk aneurysm. So also this aneurysm was located in the window of this fenestrine clips. So this cannot be, this is unclippable. So we then perform STA M3 bypass. I dissected the parietal branch of the STA with needle tungsten monopole with high efficiency. And this is the main trunk of STA. We usually perform this dissection under the microscope is conducive to accurate calculation. And this is the frontal branch of the aneurysm. And the length of the dissected branch was about, and this gently pull the vessels and completely dissociate the branch of STA. And the length was about 9 centimeters, and the vessels passed very well. And the velocity of the M3 was 7.2. And we cut the donor artery into an inclined plane to increase the anastomotic area. Also, the recipient artery can be cut into 3 small strips or in linear fashion. And this is the ankle stitch at 12 o'clock. And this stitch usually requires 3 knocks. And we should keep the surgical, keep the area clean. And this is the last stitch. and be careful not to shoot to the contralateral vessel wall. Also, we should pay attention to the knot should be square knot. And if you tie square knot, too tight were enough. And remove the clip. And there was no bleeding at the anastomotic stoma. ICG checked the anastomotic stoma was unobstructed. And there was no change of blood flow before and after bypass. Also, no change of MEP, SCP monitoring. And then we check this superior trunk aneurysm in the window of these fenestrate clips. And after tripping, ICG angiography was used to recheck the patency of the superior trunk and the anastomotic stoma. And stop the bleeding. And before cranial closure, we need to make sure that the superficial temporal artery was passing very well. So I use this 3D animation to simulate my operation. 6 fenestrate clips to completely obliterate these MCA bifurcation aneurysms. And 2 curved clips to obliterate this inferior trunk aneurysm. And then performed STA-M3 bypass and tripping this aneurysm of superior trunk and guarantee the patency of all 3 MCA branches with the multimodal neural function monitoring. Post-operative treatment focus on neurointensive care and the prevention of vessel span. And post-operative safety showed no bleeding and no infection 4 days after operation. And CTA, we can see that complete occlusion of the aneurysm. Also, the anastomotic stoma was open. And CTP showed a normal perfusion of bilateral cerebral hemisphere 7 days after operation. And in the temporal region, we can see the blood flow signals of the STA. So this patient was discharged with normal speech, writing, and limb function 2 weeks after operation. Also 6 months after operation, we can see the no recurrence of the aneurysm. Also, we can check the patency of the bypass. And in a long-term follow-up, 10 months after the surgery, modified Riken score was 0, not any neurological dysfunction. So for the main complication of reconstructive clipping and bypass is mainly the stenosis and recurrence of the aneurysm. So this is 1.5 years after operation. We can see no recurrence of the aneurysm, also no stenosis of MCA bifurcation. Conclusions. Reconstructive clipping is still a simple, safe, and effective measure for the treatment of complex MCA aneurysms. Also, because it is conformed to the normal blood flow pattern of human. So right clipping requires preoperative, accurate, and individualized evaluation, including the rostral point, clipping line, and the duration of clipping. Microsurgical skills and vascular reconstruction are the basis of treatment of complex intracranial aneurysms. And in our department, about 200 patients accepting open surgery of aneurysm per year. No more than 10 cases need bypass, but sometimes bypass technique is an indispensable technique. such like these cases below. And this is an M1 supraspined aneurysm. We can see this aneurysm was calcified and with a small branch rising from the aneurysm dome. So we performed STA, RA, MCA. This is a medium flow bypass and check the patency of bypass, and then we perform a proximal trapping of this aneurysm. And this surgery was performed with the help of Professor Zhu Wei from Huashan Hospital. And 6 months later, we can see the disappear of the aneurysm, and the distal branches feels very well. Also, this is M1 aneurysm. We can see this patient was suffer from cerebral ischemia, and we can see that this aneurysm we treated with contractive clipping, and the perforator was intact. But this patient was suffer from cerebral ischemia, so we performed STA-M4 double bypass as a protective bypass, also in order to elevate the symptom of cerebral ischemia. And we can see the complete occlusion of aneurysm, and the 2 bypass was patent. We know that ICIC bypass, intracranial to intracranial bypass, is difficult than ECIC bypass, but it was more convenient and has many advantages, including no requiring of the vasograph harboring. Also, it can be done very safely. So we can see this is a-free thrombotic aneurysms and with no cleared aneurysm neck. So we can resect this lesion and perform an end-to-end in situ bypass. Also, this is A2 calcified A2 aneurysms cannot be clipped directly. So we performed A3 to A3 side-to-side bypass, assisting trapping of this calcified A2 aneurysm. And that's all. Thank you for your attention. Looking forward to your correction.
Professor Ikawa.
Well, thank you. Thank you for beautiful surgery and presentation. And is there any question from the audience?
I would like to ask one question to Professor Zumingwi. In the third case, you showed that patient presented only with ischemia. There was atherosclerotic aneurysm, and you clipped it with a bypass. So why didn't you go for a flow reversal with just a proximal clip? As flow reversal has showed good results in MCA aneurysms which are unruptured. Why didn't you consider that option?
You mean my first case?
Third case.
Which case?
Which was unruptured MCA aneurysms, which was a dilated M1 segment, and you have clipped and also bypass was done.
Yes, I know. In that case, we mainly want to treat it with reconstruct clipping. Also, because the perforator artery can be preserved by this constructive clipping, and but the total occlusion time will be too long. So we first performed STA to M4 for as a protective bypass, and after we performed the surgery, we found that there is a decrement in the MEP and SCP signals. So we performed another STA to M4 bypass in order to elevate the symptom of cerebral ischemia. Also, there was stenosis in the initiation of the MCA bifurcation.
Thank you very much. Yes, my co-host Okay, Professor Ikawa.
Okay, what's the indication of bypass to treat the complex aneurysm? How can you select the bypass or only temporary vessel occlusion? How can you select the occlusion time or
Thank
MEP?
No. Thank you for your question. And the occlusion time, like case one, now the low flow bypass for MCA aneurysms is mainly to the vascular reconstruction of small branches, but not the main. And the occlusion time, I think that the occlusion time during the reconstructive clipping, the occlusion time was less than 5 minutes. But of my skill level, when I performed the STA M4 bypass, the total occlusion time was about 20.25 minutes.
Yes, if the temporary occlusion is time is over the 20 or 30 minutes, you can select the prophylactic bypass.
Yes.
Okay, and there are many complex aneurysm in MCA aneurysm, and if the aneurysm involves a perforating artery, for example, M1 complex aneurysm, how do you treat? Bypass or other treatment?
Thank you for your question. If the M1 aneurysm is non-ruptural aneurysm, I learned from Professor Xubin of Huashan Hospital's experience. If the aneurysm was non-ruptural aneurysm, we can perform the STA RA to MCA aneurysms. It can provide flow capacity to 25 to 70. So it's enough to the supplying area of MCA. But if the important perforated arteries like lenticular striate perforators was involved in the aneurysm neck and may be sacrificed. Now, in this situation, we should perform high flow bypass of ECA RA to M2 bypass. Also, might combine with stage ICA occlusion, chronic ICA occlusion.
However, the perforating artery, if the aneurysm involves the perforating artery, and the perforator ischemia, if you trap the aneurysm, the perforator ischemia is occur.
Yes,
and
Professor Ikawa, may I answer your question?
Yes,
because this is a very
difficult problem.
Yes, it's the most difficult part is how to preserve the perforators. Actually, even a small perforator have some delayed ischemia. It can cause some very severe complications. And so for protect the perforators, sometimes if the MCA M1 giant aneurysm it's unruptured and the aneurysm dome was quite thick, so this kind of aneurysm we can do the distal bypass, combine the distal occlusion of M2. So through this kind of distal bypass, combine the distal occlusion, sometimes most of the cases we can preserve the perforators. But it still happened in my personal series. It still happened in 12% the delayed ischemia of small perforators. So this is most difficult, because after you occlude the distal part, actually the blood flow in the aneurysm dome the velocity was decreased a lot. So actually, when it decreased to some extent, it can form the emboli. So the thrombus maybe go into the small perforators.
Yeah,
So it's
exactly.
unresolvable.
Yeah.
Yeah.
But we shouldn't trap the MCA giant aneurysm. Only
Yes.
you said only distal occlusion.
Yes.
It's better in
Yes.
our experience in Japanese
Yes. Yes.
neurosurgeon.
Yes.
And sometimes we can't avoid the pulmonary
Yes.
ischemia. Okay, thank you.
Thank you
And
very much. You can take a question from Dr. Liu Bun Seng. Liu?
Okay.
Thank you. May I ask Professor Felling if he's still around, Professor?
Professor Fellings, are you? Yes, he is.
Yeah, Professor, sorry. I have two questions for you, Professor. Because I attended some of the AO spine talk, and apparently most spine surgeon now, they believe that degenerative changes doesn't show any bone growth, or the bone doesn't grow when they do a volumetry of the bone. And they think that degenerative changes are due to changes in the soft tissue, either intervertebral disc or facet joint, or even the ligaments and ligamentum flavum, as you mentioned, some probably due to inflammatory process, calcification, and so on. So, but the main treatment now for degenerative cervical spine especially is bony work, mean we're doing a corpectomy or laminectomy. And due to that, a lot of paper now going just internal decompression by removing the ligamentum flavum, or do a fascectomy for such. What is your opinion regarding such option, especially for stenotic cervical spine, which causing a myelopathy? My second question, Professor, in your experience, what do you think that the role of fusion surgery in degenerative myelopathy? Would that surgery slow down the degenerative process in long term? Thank you, Professor.
So thank you for your question. So in summary, you've asked about options, surgical options, and in particular, perhaps some less invasive options. And the second relates to the role of fusion in the setting. So I think that one of the areas of opportunity going forward will be to personalize the approaches with regard to surgical treatment. So with anterior surgeries, my preferred approach in most patients is a multi-level discectomy versus corpectomies. And I think that that's a superior approach. And you can get to the inferior third and the superior third of the level above with undercutting. And I think it's less invasive. You can get excellent fixation and you avoid the need for a posterior approach. So that's one point. So I would say that the majority of my anterior surgeries are with multi-level anterior cervical discectomies. Okay. Then in terms of the posterior approaches, you've raised the options of, let's say, what's been called, you said resection of the ligamentum flavum. Most surgeons would combine that with a laminotomy. So it's been referred to as skip laminectomies. The effort there is to try to preserve the posterior tension band to go in. And I think that in certain circumstances, if it's a very focal compression, that's a good option. So for example, if you were to have focal ossification of the ligamentum flavum at that level. The challenge though is that most patients don't have focal compression. Most patients have more diffuse compression. The patients with very mild impairment, where often you don't operate, they have milder pathologies. And so often your hand is forced to do more extensive surgeries. If you do more extensive surgery for spondylosis, I think that a fusion is a superior option. Laminoplasty is an excellent option for OPLL where there is relative rigidity of the anterior tension and you just need to get some stabilization posteriorly. And so I think this is kind of where the options are. And then going forward, you know, will fusion be required? Well, I think if your hand is forced to do a very extensive posterior decompression in the setting of spondylosis, particularly if there's deformity or if there's a spondylolisthesis, a fusion is a better option, I think. And I think the laminoplasty, if you have a developmentally narrow canal, good lordosis, it's still a kind of a very valid, you know, that's kind of a very valid option. And sorry, I forget what the second question was.
Does fusion surgery delay the degenerative process in the future?
Oh, I see. Well, there's pretty good evidence that instrumented fusion will prevent OPLL from progressing. And in fact, if you follow patients, often the OPLL will regress and will decrease over time. And I've also seen this with spondylosis. The challenge sometimes with fusion surgery is the complication of adjacent segment degeneration. And here it's very important to restore the sagittal alignment, because if the patient is fused in kyphosis, the rate of adjacent segment degeneration is quite high.
Thank you, Professor.
Thank you very much, Professor. I would like to ask Professor Fillings one question regarding the postoperative development of C5 palsy after posterior decompression and fusion. Although this is a poorly understood phenomenon occurring up to 30%, spontaneous recovery may or may not be possible. What are your theories behind the occurrence of this phenomenon? And
So
what
delayed
is the
C5, yes. So delayed C5 palsy occurs to all of us, even with very careful surgery and careful technique. So there are mechanical factors, and then there are inflammatory factors, and then there are genetic factors. The mechanical factors are if you do an indirect decompression posteriorly and there's a significant amount of cord shift, that cord shift can result in tension on the nerve roots, and that can result in some issues, particularly if there's foraminal stenosis. So I recommend doing prophylactic foraminotomies to try to minimize that issue. The second component of this relates to the ischemia reperfusion issue. And so there is an ischemia that occurs, and then during the reperfusion, there can be an injury that can occur. By the way, I was going to make a comment on the temporary occlusion, vascular occlusion. I think some of the issues my colleagues are my vascular colleagues are running into is actually ischemia reperfusion injury. You might want to talk to me about neuroprotective strategies around this. But to come back to this, so inflammation is a factor. So patients where C5 palsy is a risk, let's say multi-level posterior decompressions, laminoplasty or laminectomy fusion, I advise a short course of dexamethasone post-operatively for about 5 days to reduce the inflammation. And these are the patients also where riluzole is very valuable. Riluzole reduces the rate of C5 palsy, and if it occurs, it's less severe. So we know if patients have some preservation of C5 function, the recovery will be excellent. If patients go to a 0 with their C5, then the recovery can still occur, but it's not as good. So the riluzole is very helpful. Then the third factor, which is currently under investigation, are genetic factors. And we're currently investigating certain genetic factors. We recently published a paper in Brain showing that a microRNA called miR-25 significantly increases the risk of patients to develop delayed neurological complications. And so sometimes it's the patient's genetic predisposition to develop these. And some of these genetic changes are potentially targetable. And so one might be able to develop approaches that could actually prevent some of these issues from occurring. So those are some of my thoughts on this very challenging issue. And all of us encountered this issue. I recently had a patient, despite all of my efforts, got a partial delayed C5 pulse. It's about grade 3 power, so it will have a good prognosis, but it will occur. You need to warn your patients, about this.
Thank you very much for these novel insights. I would like to mention, if there are no more questions, we can wind this up. Back to Professor Ikawa for his concluding remarks.
I have a question to Professor Xu. Okay.
Sure.
And how can you measure the flow? Because you use the flow velocity using microdoppler. And can you select the graft low flow or high flow, medium flow by the measurement of the flow velocity?
Actually, according to our experience, after the surgery, we measure the flow by the NOVA system.
NOVA.
Sometimes NOVA system.
MRI.
Intraoperative MRA. Intraoperative MRI. We can measure the blood flow in the donor artery. And but according to
in your video, you use microdoppler?
No. You mean Professor Xu Mingwei? He is in another hospital.
Xu Mingwei showed
can you measure?
He used a microdoppler to assess the flow. How is it possible in your place? It is some specialized probe which tells us the flow velocity.
Only flow velocity.
Because in Japan they use the flow meter, which
not flow meter.
Yeah. In my video, it's just the flow velocity, but the blood flow capacity, our hospital cannot measure it. And Hwasan Hospital can measure the blood, the flow capacity of the donor artery through the LOVA test, intraoperative MRI.
You usually measure pre-operatively by MRI?
No. Intraoperative or post-operatively. Actually, according to our experience, for an adult male patient, normally the 2 branch of the STA can replace the MCA territory enoughly. But for the female patient, normally the STA was quite small, and we will add some like radio artery to make sure there's enough blood replacement.
Okay, I see. And case 1, in the case 1, how many days do you operate after the subarachnoid hemorrhage? Because you examined the flow dynamic study. So in acute stage, you operate or not?
You mean the dorsal analysis? The dorsal analysis pre-operative? In the case 1, yes, we can analyze the dorsal through computational fluid dynamic technology. It uses the software of ANSYS software, and we
emergency.
We can measure the washer stress and relative resistance time, also the velocity of the aneurysm wall.
It's immediately.
No. No. That ANSYS software was used for blood flow analysis, and we use patient's CTA data was imported into the software for 3D modeling, and then the model was meshed to import relevant data of blood flow simulation. And finally, the hemodynamic indicators of patient were obtained. But the current blood flow simulation is an ideal model, and its accuracy and authenticity need to be improved.
So how long it would take?
Yeah.
One case we need to take about one to 2 days to complete.
So Professor Ikawa's question is how many days you operated after the subarachnoid hemorrhage?
2 days.
2 days, okay.
2 days.
Yes.
Okay, I see. And sometime in MCA aneurysm, subarachnoid hemorrhage is very sick, so-called Sylvian hematoma. How can you treat Sylvian hematoma?
So
you aspirate completely or not?
So in my opinion, sometimes the blood clot is too thick, and if the patient is if the aneurysm is not without unregular shape, we can delay the operation to 3 or 5 days, and but this has some risks. So most of the patients will perform the immediately surgery.
And if the patient have sick Sylvian hematoma, can you understand?
Yes.
You usually aspirate the Sylvian hematoma completely because the Sylvian hematoma involves a small artery or vein. Yes.
So we devote the appropriate dissection and short dissection and not complete. Your dissection is suitable for clipping, but if there are thick clot in the deep severe vessel, sometimes we didn't remove this blood clot.
Do you use urokinase intraoperatively? No?
No.
Okay. In Japan, some institute use urokinase is effective for the sick.
But we don't have that equipment.
Okay, I see.
We can go to Professor Shubin for his final remark.
You see, Professor Ikawa and the Professor Feeling. Thank you. And actually, just Shumingwei mentioned that we just finished our National Congress of Neurosurgery. So we have some competitions for the young neurosurgeons. So Professor Xu, he just got the champion for right clipping. It's a competition for the young neurosurgeons to treat the aneurysms. So Professor Yuha Hanusalimi is also one of the judges. So actually, thank you. Actually, we also invited some Japanese neurosurgeons. 3 years ago, we invited 5 of them, 5 young neurosurgeons to present their cases in our RCRC competition. But they told us that for Japanese neurosurgeons, you just invited them, not for competition.
Yeah. Please come to Japan again.
Yeah. And actually, we can organize some international RCRC competition, maybe.
We can look forward to that in our future editions of ACNS.
Yeah. After the pandemic.
Can we have the number of attendants today?
Today we have around 800 participants. in the Chinese WeChat channel. Thank you.
That is a huge
Yeah.
So I think it's time we wind this up officially. We had around 80 participants here. So thank you so much. I'll wind this up now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers and chairs, Professor Shuming Lee and Professor Michael Fellings, and the chairs, Professor Usao Ikawa, as well as Shalman Sarif. Thank you, Professor Fellings, for staying back. It was very kind of you to answer a few questions at the end of the webinar. This webinar closes our 1 year of journey of online education for the neurosurgeons around the world in this era of pandemic. And we are extremely thankful to Professor Shubin, who extended his support and translated these webinars into China. We are extremely thankful to him. I would like to thank all the distinguished faculties who joined today. Professor Shubin, Professor Atul Goel, Professor Suresh Nair, and everybody from China and India as well. Thanks to my co-host, Dr. Liu Boon Singh. Until we meet on 2nd June, it is bye-bye from all of you.